dementia or age-related mental health conditions. I will share the agenda right now so we can go over that real quickly. But my name is Carrie Bruffett. I'm a facilitator from the Kansas Health Institute. I'm Vice President for Policy at KHI. And we're looking forward to the discussion today. We're going to try to use Jamboard again. Remember when we used Jamboard in the first meeting? Good stuff. And even if you're not a Jamboard user, we'll be able to use chat and drop your thoughts and recommendations into the Jamboard for you. So that don't be intimidated by the technology. We'll use it together. But thanks a bunch, and we look forward to spending most of our time today really working on those recommendation developments. And we will also spend a little bit of time, though, preparing for the next topic, which, as we discussed in the last meeting, sort of the cycle of these working groups is to dive after the first meeting where you looked at all the topics and really did that strengths, weaknesses, opportunities, and threats analysis. Then the second meeting and then subsequent meetings will sort of follow this pattern. One meeting to look at and dig into more information about a topic, and then the next meeting to really develop recommendations. Take the first shot at developing those recommendations. Then the next meeting, move to the next topic and really dig into and have discussions, presentations that you all request, and then that subsequent meeting, develop recommendations around that topic. All through, flow through the full cycle, and then you'll have a couple meetings near the end of the spring where you're going back to those recommendations and starting to prioritize, refine recommendations. So you can still seek additional information to really make those even better for the final report that will be submitted then to the Senior Care Task Force. And we'll be using some surveys, things like Qualtrics tools, and sorry, dog, to be able to help you do some work between meetings as well. But so we'll spend a little time today asking you what kind of things you'd be interested in hearing or people you'd like to be interested in hearing from about the next topic, which is the rebalancing of home and community-based services. So that's our meeting today. A reminder of our meeting commitments: come ready to discuss and compromise. And at this point, we're throwing a lot of ideas and wanting to really get ideas from you all for potential recommendations. So be open-minded as folks are putting those recommendations together. We still want to keep our remarks succinct and on topic. I'm going to probably push us along at a faster pace than feels comfortable, and so I apologize if I interrupt you and you're really making a really good point. If we need to move on to our next topic, I'll try not to interrupt, but I might urge us to move along. So apologize in advance for that. But don't hesitate to ask clarifying questions. You can stop me and say, no, wait a second, we really do want to talk about this as a group. We're not ready to move on to the next thing. I won't take offense at that either. And then we'll make sure we end on time. So with that, instead of doing our full round of introduction, well, we'll still want everyone to introduce themselves, and a reminder that since we are also live on YouTube and I think on Harmony as well, that whenever you speak, to be sure to, or ask a question, to be sure to introduce yourself with your name and your organization or who you're representing on the working group. So just a reminder of that. But so I will want to go around and just have brief introductions this morning. And instead of asking you sort of the level-setting question this morning, we're also going to turn over to Senator O'Shea, who's going to talk about some legislation that some of you may or may not be aware of that's moving through or it's been introduced in the legislature, and she just thought it would be of interest to you all. So we want to spend a little time on that before we dive into the recommendations. So just need sort of name and organization, and this time I'll call on you in the order I see you on my screen. Jan. I think you're muted. There you go.
Okay. Jan Kimbrell, silver-haired legislator, Morris County rep.
Linda.
Linda Mowbray, Kansas Healthcare Association and Kansas Center for Assisted Living, representing aging services, long-term care services across the state.
Senator?
Kristen O'Shea, Senate District 18.
Annette.
Annette Graham, Kansas Association of Area Agencies on Aging.
Dan.
Dan Goodman, Assistant Commissioner for Long-Term Supports and Services for KDADS.
Jamie,
Amy Gideon, Alzheimer's Association.
Sarah,
Sarah Schlitter, Johnson County Developmental Supports, representing InterHAP.
Sean S.,
John Sullivan with Midland Care.
Stacy,
Stacy Carson, registered nurse with Johnson County Developmental Supports.
Tanya,
Good morning. I'm Tanya Dorfbruner with Oral Health Kansas.
and then Sean M., do you want to introduce yourself as well? Not a member of the working group, but here from KLRD.
Yep, Sean Marshall, KLRD. I'm just here to monitor the discussion.
And also point out Emma Urich, one of my colleagues, is here as a co-host, and she's going to be sharing screen. There she is, wave, Emma. And then Charles Peters, or Charlie, is here from the Kansas Legislative Office of Information Services. So if you have any technical issues, you can reach Charles in the chat, and he should be able to assist you as well. So with that, I'm going to turn it over to Senator O'Shea to talk a little bit about some of the legislation that you wanted to share with the group.
Thank you, Carrie. Good morning, everyone. It dawned on me in our Senate Public Health and Welfare Committee that some of the bills that we're hearing and working right now very much apply to access, and some of them workforce as well. So I wanted to hit the highlight of a couple of them in our committee that are doing that. I put them in the chat with the links so you can see that. The first one is about providing licensure of dental therapists. So a dental therapist is a bit of a step in between a hygienist and a dentist. They can do roughly 20 or so more procedures than a regular hygienist, and it also requires 2 years of more schooling. But in terms of having shortage to dental care, that one would touch that topic. The next one's about updating the scope of practice to APRNs. So this would allow nurse practitioners to practice independently. The next one is about expanding the pharmacist scope of practice to include point of care testing for treatment of certain health conditions. So if we think about a couple of years ago, you didn't go to your pharmacist to get your flu shot, you'd go to the doctor. And so this is essentially kind of expanding that, where maybe if you think you have strep or maybe a diabetes test, you could do that test at your pharmacist rather than having to go to the doctor. And the last one's a hot topic. I just thought I'd put it here in case some people might believe it's access, some people might believe it's a hindrance, but I thought I'd put it there just in case. Creating the Kansas Equal Access Act to authorize the use of medical marijuana. And then the final link that I provided was just a link to all the bills that are happening in Senate Public Health and Welfare, and that's just on the Senate side. So you have to remember there's the House side as well. Finally, there's one bill that's not been introduced yet. We're currently working with revisers, and some of the people on this call have been a part of this conversation. But this one would help us to expand and modernize healthcare workforce training in Kansas. And so essentially it would do two things: allow licensed practical nurses to teach CNA courses, because we're finding that we don't have enough instructors to teach those courses. We actually have more students wanting to be in those courses than we have instructors. And the next one would allow the use of simulated laboratories up to 50% of nurse aid clinical hours. So just making it a little simpler for them to get their hours done. And I will try to when that one does come to committee, I'll try to let Carrie know so she can send it to the rest of the group. Any questions? Okay, good deal.
Senator, if you want to email those links to me as well, then we can. I'm trying to copy and paste from the chat and having not mixed success doing that.
Yes, I already emailed them to you, so you should have them.
Great. So we will also send those out to the group and then post those on the working group website too, so that folks watching on YouTube can access those as well. Thanks so much. Okay. I missed Heather. Heather, I think you came on and moved around my screen, so I apologize. I missed. We're just doing some quick self-introductions.
Heather Brown, Johnson County Developmental Supports.
Great, thank you. Okay. With that, first of all, I wanted to share something real quickly, make sure you all had seen it. It may be something that is more useful to you. may be more useful to you in the next, not just for this meeting, but when you're really diving into and potentially revising recommendations. We sent it around yesterday afternoon, so I apologize. That was kind of late, so you may not have had a chance to look at it. But some of the questions and information that had been requested in the previous meeting, and we'd followed up, and Dan, thank you for providing information from KDADS as well in response to some of these questions. Followed up with some other folks as well. So there was a question, for example, about funding specific for aging mental health specialists. There's not a specific funding for having an aging mental health specialist, but you can see the response here. And Dan, I don't know if you want to talk about either one of these or take it away.
I don't have a lot more to offer there. Pretty much the information I received was from Andy Brown, the Commissioner of Behavioral Health. So I think his concern was more about workforce than it really was funding, right, in general.
Right. There was a question about training provided to CMHC staff working with older adults. Didn't get so part of the response to the other question sort of did talk about some of the credentials that are provided for varying levels of staff that can be sought. But I think that's probably a little different question than the second question, which is what actually is provided. And so I had some follow-up with the Association of Community Mental Health Centers, and it differs and it varies. So it's not like a standard training. So I think that's probably what you all are talking about in this potential recommendation. There was a question about identifying the barriers to CMHC's providing services to nursing facility residents. So Linda, I think this was came from a recommendation that you had discussed in the task force. And KDAD's confirmed, and Dan, you can follow up about this as well, but there's a state plan amendment that's in process that would facilitate the ability for CMHCs to be able to provide specialized services in nursing facilities. Linda, would it be helpful to have some additional information about that before you get to sort of like the final report? We may be able to get a status update. I think it sounds like that SPA is in process.
Thank you, Carrie. Linda Mowbray, Kansas Healthcare Association. The access really, I think it speaks for itself. We have individuals that are in our long-term care facilities that do have mental health needs, and getting them the access to services that they require to remain stable or to help stabilize and then return to the community is key.
Thank you. There was a request to find out more information about the CMS hand-in-hand training, and did not get a specific answer to the question about can senior centers be a site for training. I think the answer would be yes. It's just a matter of what would it take to facilitate that. But Linda Farrar had provided, as I mentioned, some information even prior to your last meeting about hand-in-hand, including a link to, you can actually go and watch the video modules of that hand-in-hand training that was done in Kansas. And then the first link, and I think it may not be in the version that was posted, I think it wasn't a hot link, is actually to the CMS page where this information was developed, and it's available, and there's information for training trainers as well. So that first link includes that, and then the videos is the second link. Additionally, some information about dementia-capable care training. Some information about the database. So this work group, as well as the workforce working group or subgroup, had asked questions about the database or matching services registry. That I think it was mentioned, Gina Irvay's name was mentioned a few times, as having really helped develop this, working with an organization called Rewarding Work. So, and then we also had a question about the Advancing States/Centene project, which is similar, but with a different sort of target audience. And then also a question about respite training. So we know there's more training. I'll start from the bottom up there. This was a link that Annette, I think you had provided to the free respite care training that is available. That's basically through this. Again, it's a live link. You can go to it. That actually is available now. There's mentioned there's other sources of training as well. But for the two data registries, both organizations I talked to are interested in providing more information, and it may be this work group or it may be the workforce work group as we sort of are thinking through some of the questions that they're addressing. But this rewarding work is a database matching service. It operates in Kansas, Connecticut, Massachusetts. You may have known it as the Kansas Personal Care Directory in the past. So I think at one point we thought maybe those are two distinct things. That's the same thing. It's just sort of has changed names as the organization that Gina is working with on this has changed names. There is, as discussed, a monthly fee for individuals or agency employers to try to match up to, there's no cost for the job seekers, but for the folks looking to hire, except there's no charge because it's underwritten by, in the past it's been all MCOs. It sounds like it's only United Healthcare in the coming year underwriting this, but all CanCare members can access this without cost. So it tends to be mostly self-directed individuals. Gina had pointed out that if external funding were available, to provide free access outside of, to folks that were older adults that aren't enrolled in CanCare as well. So it's really sort of the CanCare is the free access right now. And she has some information she'd be happy to provide. She sent a bunch of stuff as well and really has some thoughts about direct care workforce overall that would be, I think, really helpful for the workforce working group. But if you all are interested in that too, could share it with you all. The Connect to Care Jobs is Advancing States, which is the national organization of state associations or state agencies, for aging and disability services like KDADS. This was a initiative that was launched at the start of COVID-19, and it really is like trying to match folks that are willing to fill short-term crisis-related job openings in facilities. So it's a different audience. So at least as it started, it was nursing facilities, assisted living, long-term care, acute hospitals, etc. So that's active in all states. Advancing States is now working with a different organization, a different consulting firm to actually expand that. So they may actually have a different target audience. It may be expanded to more home care, direct care workers as well. So they're just going to be starting the outreach on that. And they said they would be very excited to share information and what sort of lessons learned from that as well. Again, either with the workforce working group or with this one. And finally, Sean, you had asked about, Sean Sullivan, you had asked a question about best practices for pairing telehealth, geropsych, either geropsychology or geriatric psychiatry. This is linked to one thing we found just in a literature review. There's maybe something that's very specific, but it actually seemed like something that might be useful for you to look at. It had a table that was sort of lessons, a combination of best practices from different sources, basically around specifically telemedicine and pairing with long-term care facilities or long-term care providers for psychosis and neurodegenerative diseases. So dementia and Parkinson's related psychoses. So that's kind of a little bit more specific, but the best practices seem to be more applicable. So it's kind of interesting and maybe something that you all could dig in before the next meeting. We also have some additional outreach to other organizations, and hopefully maybe we could get something that's a little bit simpler summary than an academic report to be able to share with the group. So I'll stop talking, and hopefully that's going to be helpful both in your recommendations today, but maybe something you could dig into all of these things and let you know, ask you if you're interested in additional information on any of these other topics that we could provide after this meeting. Any questions or suggestions?
Sorry. This is Annette Graham with the Kansas Association of Area Agencies on Aging. And I do think that it would be good to have Gina Urbe come and present on her some of the work she's doing on the workforce issues, because I think it's just such a cross-cutting, and I've been in communication with Gina and have looked at the work she's done on that, and she has some really good recommendations and ideas about that. And I think because it's such a cross-cutting issue and impacts care both in the institutions and facilities and community-based, I think that would be a good recommendation option.
Now she has a slide deck that she's working on for sharing with policymakers. So it's very in line with you all's vision to have policy recommendations that will impact access to services. Okay. Any other thoughts? I'll stop sharing. And then we'll get to the fun, starting the work on the recommendations themselves. So not that that wasn't fun. That was fun too, right? I'm going to put a link in the chat to what you're seeing here so that you can all go to it. I'm sure I can share that link appropriately. All right. You guys see that? Give me a thumbs up or a hit shake if we see it. Awesome. Great. So go ahead and click on that link. My colleague Emma is sharing her screen. So we're going to take about 10 minutes per page here to think about recommendations, and you can pull some of the recommendations or repeat some of them that you had been discussed from the task force as well, or restate them. But the goal here is to look at opportunities, the strengths, opportunities, weaknesses, threats. I guess it was in the different order, SWOT, strengths, weaknesses, opportunities, and threats, two at a time, basically, and try to ensure that you've addressed various weaknesses, various threats, strengths, and opportunities that were identified in that initial analysis. So we don't have to stretch too much to try to make it fit into these boxes, because we'll also have a fifth screen that it's like, okay, there's a recommendation that I really want to do. I couldn't figure out which box to put it in. That's fine too. But this hopefully will provide an opportunity for us to think through all the issues that you had addressed and raised in that first initial SWOT analysis. So take a minute to look at opportunities and strengths, and our first 10 minutes is going to be focused on recommendations that would use those strengths to take advantage of opportunities. So if you remember how to do this, just grab a sticky note, type in your recommendation. If you're able to zoom in a little bit more, Emma, it might be good. Although I think probably most folks, if you're on the screen, you're seeing your own view of the Jamboard. If you're not able to get into the Jamboard, you can type a recommendation into the chat, and then I'll type that and put that onto the screen so that everybody can see it. So with that, I'm going to be quiet for about a minute. About 5 minutes in, I'll start to ask folks, or if it seems like we're slowing down, if anybody wants to talk about some of the recommendations, but we really want you to spend your time typing some up. And it's okay if they're repetitive, and there are a couple that are the same. I think that's fine. A reminder too that the recommendations that we discussed at the last meeting that came from the task force, those will continue to be documented. So you can repeat them here, but they will also stay on the list. So this is just adding to that list as well. Okay. We're about 5 minutes in, so we got a little bit more time. I'm going to read off a few of these, but you can continue to type. But if you hear something that you want to ask a question about, or if one of these I read as your recommendation and you want to expand upon it a little bit, we can use the next 5 minutes to really do that. So what we see about training. So require at least 4 hours annual dementia-focused training for caregivers across all settings. Provide dementia training program targeted at caregivers to senior centers. There's a couple training. It require 9 hours of dementia training annually for all LTC employees. So we could see potentially a discussion in a future meeting about what's the right number of hours there. Require at least 3 hours of continuing education for dementia for professional positions such as doctors, social workers, and mental health professionals. So expanding that to not just the long-term care facility staff. Some others are add home delivered meals to the frail elderly HCBS waiver. Add technology services as an allowable service under the Senior Care Act program. Establish a dementia coordinator position at KDADS. You all talked about that at the last meeting as well. Establish an Alzheimer's Disease Council. Create caregiver tax credits. Another mention of the permanent dementia coordinator position. Connecting mental health centers more closely with the Alzheimer's Association. Going back to training, integrating dementia training into what education is already being required versus requiring more. Another Senior Care Act one, Senior Care Act funding to connect rural areas with community mental health centers or professionals. Identify connectability issues to the resources that may become available for home-based care and more isolated long-term care facilities. And then identify sources of funding for these mandates. So, a couple of others have been added, including establishing and funding a transition service for transitions from nursing facilities to the community. So that's something that has certainly existed in the past as well. So what does that look like moving forward? So any thoughts, or anybody want to expand on any of these or ask any questions? Linda, I see your hand raised. Go for it.
Thank you. Linda Mowbray, Kansas Healthcare Association. I wrote on a sticky note and then I don't know what I did with it, but I will put it in the chat so you can put in there. But I think we have, I would recommend that we leverage some of the resources that we already have, such as the PACE program. How do they successfully, and they do, transition people back and forth between their home and their day services? That's a changing locations for an individual can be quite difficult when they have dementia and quite unsettling. They do it successfully, and I think that might be a recommendation to utilize some training from them to tell us all how we can do that successfully, and then lead that into transitioning to other settings.
Thank you, Linda. We have about 1 minute before we're going to switch to our next topic. Anybody else have something to expand upon or a question about something you see here? Okay. So look at the top of your screen. If you're on Jamboard, you probably aren't seeing what Emma is showing us, but if you're not, if you've got two screens and you can see it, at the top of your page, there's a picture that'll say like 1 out of 6. That means you're on the first screen of Jamboard. Click on the little caret arrow to the right, and it'll take you to the next frame. And you should see a bunch of green sticky notes this time. Folks on their way there. So what we will do now is, again, take about the next 5 minutes. You look through the opportunities before, but now look through them as you're also looking at weaknesses. So particularly look through the list of weaknesses there, read through those from the SWOT analysis. And think about, are there other recommendations? Are there different recommendations, or maybe slight modifications on something that you may have put on the previous screen that you want to add here? So let's take a couple minutes to look and then start thinking about additional recommendations. And again, in about 5 minutes, we'll ask folks to share and expand. Thanks. Got a couple minutes before I'll ask folks to expand, but just looking through the weaknesses, a lot of things we talked about and from your questions in the last meeting, workforce, and then the difference of availability based on geography, and then just limited availability of some of the staff as well. So you should think through recommendations that really would get to those weaknesses. I think it'd be helpful, and I see some that definitely do. Okay. We're at about 5 minutes. So I will do zoom in a little bit, make sure I can read a little better. I'll read a few of these, and again, if folks want to jump in and expand, it'd be great, and or ask questions. So see a few that are related to rates. Increase the HCBS braille elderly and physical disability provider rates. Create a mechanism and statute to increase the physical disability and braille elderly waiver rates annually or every other year. Make sure we're not covering up anything. There we go. And there's some about developing and investing in a workforce plan to increase the availability of in-home and facility staffing. Oh, I missed that big increase all HCBS rates one there. It also went back to the first thing. Others about related to workforce, work closer with the state's education to increase students' interest in the field. Eliminate barriers to training for entry-level staff. As Senator O'Shea mentioned, share staffing resources, specifically those that are difficult to recruit for or retain where appropriate. Sort of that idea of the shared resources, even across sectors, is becoming discussed even more and more. Retention bonuses or payouts for workforce employees who stay on the job. Increasing community college and technical school funding for coursework directly related to geriatric health support services. And then some that are and utilize agency presence already in some communities with expanding, adding more of these geriatric targeted services. Maybe I may not have read this one. Develop career pathway initiatives to increase workforce for community-based and self-directed care service arena. But that's definitely one of the issues that the workforce subgroup is looking at, that career pathway. One that you all talked about in the last meeting, providing training for family caregivers. And there's also talking about providing transition planning in long-term care that includes nurses and direct care staff to make the adjustments safer and less stressful for all. And I don't know if I read the workforce tax credits to help with workforce shortages. So anybody want to expand on any of those or add or ask questions about them?
Carrie, this is Tanya Dorfbruner with Oral Health Kansas. I might just, I have to some extent less of a dog in the fight than a lot of the other stakeholders here, but I'm really struck by the fact that workforce is a major issue here. It's always been a major issue. It's gotten much, much, much worse. Rates were mentioned several times, and so I'm the one who create the mechanism to increase the rates regularly. Sticky note. I think if we are at a point where we value this service system as we should, we need to create a way to respect that in law and not have to basically have stakeholders come to the legislature and essentially beg for new money constantly and get it only occasionally. So I just feel like that's that's a pivotal piece of this whole story. So thanks.
Thank you, Tanya. Not to put you on the spot, person who wrote this, but person who wrote share staffing resources, specifically those that are difficult to recruit or retain where appropriate. You want to talk? I'd like to hear a little bit more about that.
Sarah Schlutter, Johnson County Developmental Supports. So I put that in just because I think a lot of times there's bigger providers and smaller providers, you know, whether you're talking about any sort of service delivery, and there are some specialized or professional positions where I think places have difficulty hiring for or retaining, maybe developing something where some of those positions can be shared or that knowledge expertise can be shared. I think that helps all of us.
Great, thank you. Are there any regulatory or legal barriers to that, or is that more trying to set up an environment where that could work?
Sarah Schlutter again. I'm not sure that that's something that we'd have to research more. I was even thinking, you know, of nursing staff or RNs or even developing something where we all have difficulty finding a doctor that works with a lot of the people that we support, or, you know, mental health professionals. So just developing resources or sharing, but the legality part or licensing we'd have to delve into deeper.
Thank you. And that could be the opportunity too. Think about those policy recommendations. If there are those barriers, that could be a recommendation to develop to facilitate it. All right. Any last thoughts before we on this page before we turn to the next? Okay, go ahead, Emma. Take us to our next screen. So remember, folks, just click on the little right arrow at the top. We should be a 3 of 5. Now you should be on a page that has pink sticky notes. And this is the interesting one. You start to think about threats. The last one's always really interesting because it's threats and weaknesses together, right? But this is threats and strengths. So thinking about recommendations through the lens of how can you use the strengths that you all identified of the system or the state or the people that are being served to avoid or to mitigate some of the threats that were identified. Some of these go back to workforce again. Some of these relate to funding as well. So there may be some similarities from your last screen, but let's try to see if there's any other recommendations that that are sparked by looking at these two together. And again, about 5 minutes in, I'll ask for expansion. Thanks. One thing that can be challenging when we think about these recommendations is to go back to a point that you discussed in your first meeting is how could these be potentially policy related? So I think it's good to get any of these ideas down because it may be in the next round when you're really refining these that you might be able to combine a couple, some reasons to do it with what it is that the policy could implement. But as you're thinking about them, challenge yourself to see if there's a potential policy implication for a recommendation and really try to target that. But don't stop writing the other ideas too, because I think those are helpful to get down. Okay, I'm going to read a few, sort of try to theme them a little bit, and then again, ask for questions or some expounding upon. Caregiver burnout was the first threat on the list over there, and I see a few of these really focused around caregivers, including in the bottom right corner, include how to address burnout in the state Alzheimer's disease plan, caregiver burnout training annually. There's a thought too about caregivers don't always realize they're caregivers and don't know who to ask for help. So maybe even thinking how to defining and ensuring that folks realize what is out there to support them. Utilizing local Alzheimer's Association chapters for caregiver burnout and self-care. Use the association to promote their resources and do outreach to local agencies, long-term care facilities, and community mental health centers. Increasing access to respite and adult day services, which are other topics, especially adult day, is something that you all are going to be looking at later as well. So it seems very much tied to that caregiver burnout. And identifying best practices models reimbursement that would increase availability of day centers. One that I think is really interesting, educating the community about statewide ADRC, the Aging and Disability Resource Centers, as a resource to learn about available resources for individuals needing assistance, information, and long-term services and supports. Sometimes at KHI, we get questions from, hey, what do we do in this situation? And it is a good percentage of the time that sort of directing folks to contact or suggesting that folks contact the ADRCs really helps resolve or helps get them to the next stage of resolution for the issue. Either that or one of the ombudsman offices often can really help move things along. There's others about using the Alzheimer's Task Force and state plan to craft strategies and recommendations to prepare for the growing demand for services. That's related to I think there was an item about, hey, maybe it's on the previous screen as well. Get ready now. It's the continued aging of the population isn't in the future, it's now. And I think I hit most of it. We use the Alzheimer's state plan to prepare for the growth. Oh, those are very similar. The two that are on top of each other. One is to prepare for that growing demand for services. Incentivizing specialization for students to specialize in geriatric mental health is also included. All right, so who wants to ask a question about one or dive more deeply into one of the recommendations that you've added?
Hi, Sarah Schlitter, Johnson County Developmental Supports. I had added one, but I don't see it, so I maybe didn't do it correctly. But I had put one in about, I think a lot of us have knowledge care experts or trainers. And so maybe developing some sort of network and offering free dementia-focused training that is available to any provider, any caregiver.
This is Senator O'Shea. I have a question, maybe comment. It appears that there really is a lack of just understanding, knowledge, training, education, whatever you want to call it, for this. And it makes me wonder how much we, you know, are the community colleges, are the colleges, are the CNA training programs, are they aware that there's such a gap? And if they were aware, would they potentially change some curriculum to kind of bridge the gap between education and the real world, if you will?
Heather Brown, Johnson County Developmental Supports. So we serve adults with intellectual and developmental disabilities. We see a huge gap in knowledge with physicians, nurses, and the like in providing medical support to the individuals in our services. So I definitely think that there is an opportunity for more education in nursing programs, medical school, whatever it might be, on all of this, on the aging population, their needs, mental health needs, all of it. So I think your Senator O'Shea, your thinking is absolutely on track with that.
This is Jamie Gideon with Alzheimer's Association, and there is no specific dementia training requirement for CNAs here in Kansas. So that's also another gap in the education.
Okay.
This is Sean Sullivan, Midland Care. My sense, being involved with the coalition on one of the pieces of legislation that the senator referenced earlier on expanding curriculum and staff faculty ratio and all that, is the community colleges are just trying to keep up with the demand that's there now, and they have a hard time expanding the training and course offerings and all that. So perhaps some policy advancements with some of the things that are out there now will help with that. I did put the sticky note on the day centers, and the reason for that is in the PACE program, we serve around 45% of our patient or participants, as we call them, have dementia or some level of cognitive impairment. And the reason that PACE is successful with that in this model is particularly because of the day center system and those supports, and often because of caregiver burnout, which has been mentioned a couple of times. We are able to bring them into the day center for 1 day, 2 day, 5 days a week, whatever it is, whatever's needed. And that is really successful. The issue, though, is really PACE is more targeted to the Medicaid only or dual eligible population. And it's hard to do in rural environments because of the federal limits. But that does not mean that there couldn't be some other system. I don't know necessarily what the policy recommendation is here. It's kind of hard to define and think about, but doesn't mean there cannot be a non-PACE sort of system reimbursement advancement of kind of day center component of that is highly successful with being able to keep people at home through that.
Thank you all.
Stacy Carson, Johnson County Developmental Supports. I just wanted to say I am a recent graduate of an RN program in a community college, and I do feel like there was an intense focus on normal aging versus abnormal aging. So I thought that was great. I didn't see a lot of focus, though, on the mental health of older adults that would be outside of maybe a dementia diagnosis, and certainly not much curriculum surrounding intellectual disability.
Thank you, Stacy. I'll also note that early on, I should have asked you to be able to introduce yourself. Kendra Baldridge from KDAG has also joined. One of your colleagues has joined as well. So let's go ahead on
Good
now.
afternoon. Thanks, Carrie. Sorry.
Hey,
or morning.
sorry.
Still morning. Good morning.
Thank you. Okay, so let's go to the next slide, next sheet. So again, go up to the top of your screen, push the little arrow. Should look at bluish. Oh, is that turquoise or blue? Yeah, blue. It's the color of the sky in Jan's background.
Yeah.
Yeah. So now, sometimes this is the hardest one. You look at threats and weaknesses, right? You're looking at the threats and the weaknesses. Where's the hope, right? But the idea here is to think of recommendations that can both minimize weaknesses and avoid threats, or maybe there's something together that says those two things together really need to be tackled with a recommendation. So we'll give about the same amount of time. Sometimes it's a little harder the further you get along to have new recommendations, but look at both of these lists. You've seen both of these lists, but look at them together, see if it sparks anything new. And I'll come on here in a few minutes and see what we're coming up with. And then we'll also have a few minutes to go to the next screen, which is like any other ideas that didn't really fit in neatly into any of these boxes. But take a look at threats and weaknesses, and be back with you in a couple minutes. A note as you're still looking at these about how what we'll be doing with these recommendations that you're developing. So in our meeting notes, we'll send out all of these recommendations that have been developed in these sticky notes, kind of number them and put them in a big matrix that shows them in each quadrant. So you'll see them all together in one list. You can see where they came from, and hopefully then will really help spark when you're getting into the refinement and prioritization and characterization of those recommendations, maybe opportunities to merge or say, oh, those are two that are similar, but how can they build on each other? So this is great. And you guys took up the challenge of this being the hardest one by taking it on and still coming up with great recommendations. Okay, this is Carrie Breffett back again from KHI. Can only handle so much silence, right? You guys are very productive though, working this way. I'm going to read a few of these, and then again ask for some expansion or any questions. And when I see it, there's something else I need to add to one that we added for someone. So there's some about case management. Adding case management services to the HCBS Frail Elderly Physical Disability and Brain Injury Waiver. I wonder if we could think about some of the community care coordination. So Dan might be able to speak to that one a little bit as well. But there's another one about adding more case managers for CanCare to enable actual visitation with residents, participants, and the remainder of that one I'll add to it. That I see in the chat is that infrequent on-site visits can allow for many issues to slip through undetected or unstated. It's an issue that was raised, for those of you in the, actually probably there's not crossover with working group A, the issue of coordination and CanCare case managers was discussed Monday in the quality of care and protective services working group as well. So a similar recommendation about more case management. Creating incentives using civil monetary penalty funds to provide advanced training for all levels of caregivers. Universities to include dementia and mental health issues with older adults into curricula for social work, nursing, med school, and other healthcare or social careers. Non-degree seeking course offerings at high schools or community colleges to educate and prepare people for caregiving positions. Courses not tied necessarily to career paths, such as CMA, CNA. More flexible services, less stringent regulations. Regulatory flexibility regarding services and delivery of services, that seems related. Flexibility and staffing requirements for staff serving older adults in the community. Review established requirements to ensure they're aligned with the tasks that are provided. Increasing provider rates, that sounds familiar. Remember that from the first screen as well. Providing PACE in more areas of the state, also something that we've seen on a couple of the screens. Developing a program to attract providers to areas with shortages. There's another one about opportunities to expand PACE to other areas of the state and maybe eligibility for the program. Funding would need to be appropriated to support it. I think I've read all of them. If I missed any, I apologize. So how about somebody expand upon one of these while I go back and add to this one recommendation from the chat. How about the one, again, not meaning to put anybody on the spot, but interested in the one about creating incentives using the civil monetary penalties to provide advanced training for all levels of caregivers.
Linda Mowbray, Kansas Healthcare Association. The civil monetary penalties funds are a fund, for those that aren't aware, that if a healthcare facility does have a deficient practice and a fine is leveraged against that facility, those monies go into a fund. KDADS has discretion with supervision from CMS, Centers for Medicare and Medicaid, in how to use those funds. Typically, they do keep a reserve in case it's necessary to bail out a home that is going into receivership, like happened a few years ago, that used a lot of money from the fund. But in order to incentivize caregivers to go through advanced training, it seems like there are some great training resources out there, but given the burnout and the hours that they work and many other barriers, providing at least some financial incentive to going through those programs and advancing their education in dementia might be a step in the right direction.
Thanks, Linda. Anyone else have any thoughts on this screen?
Yes, this is Annette Graham, Kansas Association of Area Agencies on Aging. And in regards to adding the case management service for the FEPD and BI waiver, I just wanted to current service under those waivers is care coordination, which does differ than case management. So that's why I put that recommendation there, because care coordination tends to focus a lot on coordination of medical care. And we know with these populations, there's a lot of social determinant of health and other types of issues, social kind of issues that really impact their ability to remain in the community and to have those kind of service needs. So just wanted to say that.
Thanks, Annette. And we want to distinguish that from targeted case management too, which has even more specific meaning. So you have the sort of the broader meaning of overall case management. Am I correct? We don't want to just put targeted case management on there necessarily, or would you define it similarly?
So a lot of times people, I think, understand targeted case management better, which is what was available prior to Can Care, that it was a TCM service, very person-centered, and addressed kind of the whole person issues. So yeah, that might be a better way to say that. Thanks, Karen.
And not to have it confused with administrative case management either, which is also out there.
Right. That's what I was trying to distinguish. Which one we were talking about?
Yes, and the administrative case management service that we have available in Kansas, thanks to legislative support for that, is really focused on helping the people for the FEPD BI waivers once they've been assessed for that, to help them access Medicaid. The financial eligibility is focused just on the Medicaid eligibility service assistance.
Thanks, Annette. I think those are important. We can make sure that that's distinct, because what you're definitely talking about does sound like the previous targeted case management. Linda, I see your hand raised as well.
Linda Mowbray, Kansas Healthcare Association. I have a question for Annette or others. When we talk about case management or targeted case management, etc., for the different waiver programs, what's out there for the private pay individual? Is the service available, and is it something that insurances pay for, or do families pay for, or is it not available if you're on your own funds?
There are some private pay options out there. I don't know how widespread there are, but there certainly are some private pay that people can pay for. I don't know that insurance pays for it. I think it is a private pay kind of to help people navigate the system and access, locate resources and services. Yes.
And I also know that there are AAAs across the nation that have done private pay and probably still do private pay. I think it's all dependent on the appetite of the public to pay for that service, because without public funds, that service can be more expensive than what they're accustomed to with some of the public programming. But I know that some of the AAAs have been very successful in other parts of the country with some kind of private pay options. The kind of the issue, if you seek those services in the public sector for the folks that are on Medicaid or something like that, is a lot of those folks have incentives to funnel clients to specific agencies, so they get a kind of a narrowed menu of choice options. So,
Linda Mowbray, Kansas Healthcare Association. I don't know where it would be appropriate to list that in here, but I do think we need to keep an eye on the private pay individuals, because yes, they're still out there for a while, and I think we're missing an opportunity to help those individuals who are not quite ready for Medicaid But the sky's not the limit on their pocketbook in accessing the resources.
Jan Kimbrell, silver-haired legislator. To follow up with Linda, would that not be where the home-based home community services help out immensely on the private pay folks that don't have the insurance, that they can get the information through something like the perhaps the Area Agency on Aging and ADRC to make that known that that's where that information is, and that's in the home-based services sector, not in the CanCare type of setup? That's a comment or a question, or
Jan, Annette might have more to say about this than I do, but I would say this, that you are correct, that the EDRC and AAAs, that's primarily what they do, right? Is they provide information assistance on your options. However, there are folks that are still living in the community that may not have a lot of family supports or community support. And so getting that information and understanding what's available is one thing, but then some of them have challenges acting on that and following through and getting things coordinated to help set those things up. And that's where that case manager can be critical, and just helping them with the follow through.
Exactly. Thank you.
Annette Graham, Kansas Association of Area Agencies on Aging. Yes, the ADRC Statewide Resource Center is the great place to start for anybody, regardless of income or needs. If they're seeking information on long-term supports and resources, individuals of all ages, all abilities, and of all incomes, that's a great place to start. It's an easy 1-855-200-2372 number, so people can call that. We can refer them to their local ADRCs and provide them information. There's also a service under the ADRC called Options Counseling, which is more intensive to really help people, give them the information and try to give them the resource information so at least they can know where to start and what some of their options are that's really person-centered. So sometimes people, if they're not Medicaid, Senior Care Act might be able, that we have case management under Senior Care Act and some under the Older Americans Act, and then the private pay option. Thank you for bringing that up.
Well, thank you. Good discussion. And so see, I figured I would reverse jinx us if I said, oh, it's really hard to fill out recommendations on here, but instead you had a bunch of really good ones and really good discussion. So that's great. So in the interest of time, instead of going to the next screen, which you're welcome to if you're looking on Jamboard, it's just like any other recommendations that didn't really fit in any of those boxes. You can share those, but I also want to make sure we have time to get input from you all about what you would like to hear and what information you would like to have for your next meeting as you switch gears and start talking about rebalancing of home and community-based services. So actually some of the discussion we've just had is relevant to that as well. So you can add to that screen. Anything that you type on this screen, we will add to the meeting notes, and so that everybody, including the folks watching on YouTube and all your colleagues, will see that as well. But Emma, you can go ahead and stop sharing screen now. And I will just sort of open it up for discussion now. So thanks a bunch. Thanks a lot for the thanks a bunch. Thanks a lot. That's really professional sounding. Thank you for all the great conversation and discussion. You're going to have a really good starting point. More than that, just a starting point. You're very far along in getting recommendations developed. So again, we'll have a future meeting where after you've had an opportunity to look at those notes and look at all of the recommendations that come in all the topics, because I imagine there will be some crossover even as you look at different topics. You'll be able to refine those recommendations and make them even more actionable and policy oriented and so on as you go. But you have a wonderful well to be drawing from moving forward. So our next topic for this group at your next meeting, which is February 11th, as a reminder, again, 9 to 10:30 a.m., will be a discussion. It will be the discussion meeting, so the discussion and presentation meeting focused on the rebalancing of home and community-based services. So wanted to ask now for you all in the next few minutes to think about and share any ideas about any questions you would want to make sure that maybe that discussion or some presentations could help answer, help identify supplemental experts that you might be interested in hearing from, any data or information requests we could do on your behalf in advance of that meeting. Just thinking about rebalancing. So take it away. Anybody have any ideas for folks they would like to hear from? Maybe presentations you've heard in other settings that you think that the folks on this working group would benefit from related to rebalancing. Do folks have an idea what we mean by rebalancing home and community-based services? Annette, you shook your head first. I'll have you take your, let's define it, because sometimes we think about it as rebalancing home and community-based plus as opposed to facility-based services and so on. But what do you think it means?
I think it means, balancing the availability and funding for facility-based, institutional-based versus in-home community-based services. And I know we had some presentations early on from KDADs on some of the data, but I think it might be important to just kind of look at what those trends are for nursing home utilization, facility, assisted living versus home and community-based service waiver. And if there's any data on, that kind of data can kind of help us see what's been happening in the state over the last several years, and then just kind of overlaying that with the demographic trends that we know. And information, I think, also about that growing aging population, but also we know that the fastest growing population is age 85 plus. And what is the percentage of that population that is likely going to need long-term care? And I think that kind of data will help us be able to think about what kind of action, legislative action, might be recommended as we look forward to the future. And again, Annette Graham, Kansas Association of Area Agencies on Aging.
Jan Kimbrell, silver-haired legislator. To me, home-based means in my community, within my short-term mileage radius, and not going 120 miles or even 90 miles away to get services. We have very few. We do still in the community in which I live in. We have a hospital. But so many out here and farther west, their hospitals have been closed, and their services are very few and far between. And there's no, it's been explained to me it's not profitable to have those services out there. So that those of us that live in these outlying areas, we should be grateful for these telemed type of opportunities, and yet our connections don't make it possible and our transportation doesn't. So I'm all about home-based within my little town or my little community, and not, our definitions are different. So.
Thanks, Jan. So
Yeah.
potentially in addition, sort of the geographic, not just those trends, but are there geographic disparities or differences?
Yes. Thank you.
I think that would be helpful. I think we could, that's something, Dan, we could follow up and see if we could stratify the data at that level to be able to understand that. Jan and I were talking before the meeting started about, and some of you have heard, if you've heard me talk before, about my grandmother who lived in the house she was born in North Central Kansas for all of her life until just the last couple of weeks of her life, when couldn't get services to come out to her where she lived in rural North Central Kansas. So she got great services where she went, but she would have much preferred to be able to pass in her home. And so having people to be able to have those options, I think it's different depending upon where you are. And it's not just geography, it could be income, it could be just the availability or knowledge of those resources as well. How about other, we have a couple more minutes to talk about other data or presentations or maybe particular people you'd like to hear from. I think we've got a good starting point.
Annette Graham, Kansas Association of Area Agencies on Aging, and I'm not sure if it fits with that topic area, but having Gina Hervé present because in a rebalance, if that's going to, we have to have the workforce on both sides of that.
So, and hers really about direct care workforce, absolutely related. So, yeah.
And just to add a little bit to that discussion, I too am concerned about, accessing services in the community, right, during this kind of in the middle of the pandemic and the aftermath of the pandemic, because, I think everybody's struggling to capture the same people to serve, whether it's in the hospitals and nursing facilities or home health. And obviously there's a tiered approach where you get paid in the amounts of pay. So I worry that those areas where, like you mentioned, Carrie, that there's not services available for folks that, whether on public or private, just because there isn't the person to deliver the service. And so I think we need to do whatever we do, we need to be considerate of how that affects all three of those tiered service areas. Because if we don't do that, you create an imbalance, and then you create different issue or a worsening issue for a workforce. So,
Thanks, Dan. Okay, we are almost at time. If you have other thoughts after we get done with this meeting, feel free to email them to KHI. We'll follow up with your co-chairs. Sarah and Senator O'Shea, and sort of map out and plan out what the presentations could look like. And Dan definitely will follow up with you about some of the KDANS information folks have requested as well. So any last thoughts before we wrap up for today and reconvene together at 9 a.m. on February 11th?